Begin our third hearing of Budget Subcommittee 3. Today's departments that we will be hearing from include the Department of Managed Healthcare, Office of Systems Integration, OSI, Department of Healthcare Services. Let's go ahead and get started. Item 4150, Department of Managed Healthcare, with the overview. Issue 1, page 3 of the agenda. Thank you for coming. Good morning.
Good morning, Madam Chair. My name is Marta Green, and I serve as the Chief Deputy Director of the Department of Managed Healthcare. With me, I have two of our Deputy Directors, Cassandra McTaggart, our Deputy Director of Administration, and Jenny Phillips, our nearly brand new, Deputy Director of Legislative Affairs. So I'm pleased to be here with you today to talk about 8 budget change proposals that will help the Department achieve its mission to protect consumers' healthcare rights and ensure a stable healthcare delivery system. So the overview of the Department: we license and regulate approximately 137 full-service and specialized health plans that provide coverage to more than 25 million Californians. We regulate just over 90% of the commercial healthcare market in the state, and we're specially funded by annual assessments on health plans with no general funds. We have some small reimbursement authority as well as some small federal grants. We have a number of programs. I'd like to highlight a few. We have a consumer help center that works to resolve consumers' healthcare complaints or issues that they have with their health plan. Since 2000, we've assisted approximately 1.6 million consumers in the state. We also license and oversee the operations of health plans in our Office of Plan Licensing. We conduct routine and non-routine surveys of health plan operations on a 3-year basis. We review the financial solvency of health plans, conduct rate review in certain market segments, and enforce the law when we find violations.
Thank you. Could you go on to responding to the questions on page 4 of the agenda?
Of course. So the first question was the overview. The second question, I believe, was please provide an estimated time frame for the completion of the timely access report. I'm pleased to report that the report is in the final stages of review and will be ready to release to the public this spring.
We wanted to follow up on that, not only because it was legislatively required, but we're, anxiously awaiting the results of the report so we can then look to you to figure out what actions you'll be taking to really try to improve the timeliness of services being provided. So from my perspective and the perspective of the staff, the report is critical.
Absolutely.
So we look forward to receiving that as soon as possible. Any questions or comments from LAO or Finance? Howdy. We just started with the overview on Office of Managed Health Care. Any questions you have before I open it up to public comment? Great. Public comment.
Hi. Good morning, Madam Chair and members. My name is Tam Mon. I'm with Health Access California. We were the organizational sponsors of the underlying legislation to establish the timely access standards, as well as Senator Hernandez's SB 964, which requires the department to review plans' network adequacy and their obligations to provide timely access to care by plan product. So with these reports, we will be able to know whether plans are meeting those obligations and whether patients are able to get the care that they need when they need it by plan products, so we could see what's going on in Medi-Cal, in the individual markets, large group markets. And we too, like the legislature, are eagerly awaiting these reports. Thank you.
Linda Way with Western Center on Law and Poverty. We too have been working closely with the department on the timely access reports and are anxiously awaiting it as well.
Michelle Cabrera with SEIU California. Just want to also echo the comments of my colleagues from Health Access and Western Center and look forward to seeing the results of this report.
Madam Chair, Fred Seavey, National Union of Healthcare Workers. I have a broader issue, and it pertains to the timely access and also enforcement of Mental Health Parity Act. We have great concerns and would like to request greater oversight of the Department of Managed Healthcare, especially with respect to enforcement of timely access laws and Mental Health Parity Act on HMOs. And the basis for our concerns is our organization's own experience over the past 5 years in bringing a complaint to the agency regarding Kaiser Permanente. In 2013, after the agency issued a $4 million fine based on our complaint and issued a cease and desist order and ordered an expedited follow-up survey, we've been very concerned that the response has been very slow and enforcement has been very slow. The continued violations by Kaiser have been documented by the agency's own investigators in a survey report that was issued in February of 2015. And we've seen, I know you, Madam Chair, were part of the joint Senate hearing in December where the family of Barbara Reagan testified their mother committed suicide in the midst of a 2-month wait for a psychiatry appointment. And we've submitted additional reams of documentation to the agency of ongoing violations by Kaiser. For example, in the Sacramento region alone, fewer than half of the first-time adult patients are receiving non-urgent psychiatric appointments in a timely fashion. So we just don't understand, why is the agency not enforcing these rules? These are very fragile consumers and patients and need the state. I mean, as the agency staff just reported, that part of the mission of the agency is to be a consumer protection agency. We're just very concerned. This is the state's largest HMOs, well-documented violations. It's a serial violator of the law, but we don't see any enforcement. And we'd simply like, as I said earlier, for the legislature to provide greater oversight of the agency and ensure it's performing its mission. Thank you.
Witness.
Hello, my name is Dr. Melinda Ginn, and I'm here also with Fred Seavey, and I'm a provider, or was a provider at Kaiser for over 20 years, and was one of the people that worked intensively, actually, with the DMHC to try to bring about reforms in the service that we were able to provide to our patients, because we saw every day patients struggling with lack of access to care that continues to this day. Despite the reports that have come out from the DMHC, we really need them to act to enforce their own findings and to get Kaiser into compliance. We were not able to do that from the inside. As providers, we advocated continuously for the more proper care and service of our patients, and we were not able to effect sufficient change, and the violations of both the timely access regulations and the parity laws continue to this day. And as a provider, I'm here to really implore the DMHC to take action to enforce their findings on Kaiser. It's the only way we'll get Kaiser to ever comply with the law. So thank you.
Thank you very much. You know, let me just add a comment. I feel compelled. You know, when I read in the agenda the notion that a large portion of the health plans miscalculated their survey results, you know, not only as a legislator who takes my oversight role very seriously as a consumer, I did sit in on that hearing. It gets a little old in hearing 3, and it's not just your department. Every agenda we've had so far, every report that should have been before the legislature, I have heard testimony about it's late, and there's been one excuse after another. And the point of the reports is not busy work. It's to give the legislature the information we need to hold state departments accountable, to do our oversight role. And so it feels like a waste of my time, your time, and the public's time when we have these conversations, when members introduce legislation requiring these reports and we don't get them, or there's delay after delay after delay. I can't imagine, given the resources the health plans have, how they could miscalculate survey results. That's troubling, because I'm not sure if that was a lack of clarity on the front end or willful negligence on their part. Nor should I be in a position to have to figure out which is the answer. I am certainly hoping that, as you say, spring, that it's before May revise.
That is our intention.
Excellent. And I hope that all of the state departments that come before Sub-3 and are within the sound of my voice get the seriousness with which I utter these words about our expectations, about the reports that we are asking. It hampers our ability as the legislature to do what the general public expects of us. And there can be consequences. I can begin to not hear budget change proposals. I would hate to have to bring that kind of hammer down, because that doesn't help you. But if we continue to not get the information we need, I'll act accordingly. So I do hope to get this report before May revise, and I appreciate that. Any other comments now that I've started the hearing going off? Senator Monty?
I just echo your concern. When we need information to do our job, it would be helpful to have an accurate status report with a target date, not a general, we're working on it, and maybe to give us what you already have so that we get a sense of the progress that's being made.
And, and then we need to talk to the health plans who miscalculated their survey results. I need a further explanation on what that means. Well, I don't know what that means.
We'd be happy to set up a follow-up conversation.
Appreciate that greatly. Thank you very much. Okay, with that, we've heard public comment. Let's move on to issue number 2, infrastructure and support services, page 5 on the agenda.
So the overview of this proposal, the DMHC has experienced significant and rapid growth since the enactment of the Affordable Care Act. In the past 5 years, the DMHC has added more than 90 program positions, which represents about a 26% growth in our department. At the same time, we only added 1 additional position in administrative support services. These are things like human resources, budgets, accounting, and the like. As such, we have a significant shortfall in those functions of the department, and so we're requesting 2 permanent positions, $247,000 for fiscal year 16-17 and $234,000 for fiscal year 17-18 and ongoing to address those position shortfalls.
In the write-up, I get the impression that you're saying even with these additional resources, it may still not be enough for you to complete the work before you.
Well, we want to start.
Even with the bottom of page 5 of the agenda, even with these resources, OAS still experienced difficulties completing assignments within designated timeframes. It gets back to kind of the time frame issue. While OAS has prioritized certain less crucial tasks, the workload must be addressed. With the requested resources, DMHC will not be able to address its critical administrative activities in a timely manner.
I think it's supposed to say without these requested resources, maybe.
Okay, I got the impression that it was saying that even with this, it wasn't enough. So if you're saying that you're fine, then that's fine. Because I am reading that correctly, right? With the request. So we'll follow up. But if you're saying that with these resources that you're fine, then that answers my question then. Anything else you want to present on this? LAO? Finance? Any public comment on issue 2, infrastructure and support services? Seeing none, we'll hold this item open. Moving on to issue 3, End of Life Option Act, AB 15, Extraordinary Session 2, 2015.
So as a reminder, this bill authorizes adult Californians suffering from a terminal disease that meets specified criteria to request and self-administer an aid in dying prescription drug for the purpose of ending their life. The bill does not specify whether health plans are required to cover this aid in dying medication or how a health plan may decline to cover the aid in dying medication. It does, however, outline various procedures and consultations that must be performed and documented prior to the dispensing of the aid in dying medication, but it doesn't specify whether or not any of these steps must be covered by the health plan. So we're requesting $244,000 for fiscal years 2016 and 17 and 2017-18 to address the short-term workload associated with conducting legal research and policy analysis related to this bill and promulgating a regulation package. Specifically, the regulation will provide clarification and guidance to health plans regarding the overlap of current Knox-Keene coverage requirements and the requirements of the bill.
Looking at the projected timeline for the regulation development, how realistic is it?
We're fairly confident that we're going to be able to promulgate the regulation in calendar year 2017.
Any questions you have on that?
I'm glad to see the department's pursuit of this. Just to be clear, the Act is silent about insurance company obligation, which can be interpreted that there is no mandated obligation. That was the intent as one of the co-authors. What we know from other state practices is that some plans will cover it and some won't. We do know that Medi-Cal Medicaid resources cannot be used to pay for the prescription, but they can be used for certain hospice care, palliative care support. But glad to see the focus on this and look forward to working with you on it.
And I think given that the fact that the language was open, a timely promulgation of regs is all the more critical, which is why I asked the question about how realistic these timeframes are.
But it is important, I think, to underscore that the act, as passed and signed by the governor, does not require promulgation of regulations for the implementation. All of the requirements for physicians, for patients, all the forms are included in the act. So at the time that it becomes law on June 9th, it will be available to eligible patients and voluntarily participating physicians.
Thank you for that clarification. I appreciate that. LEO Finance, no comment. Any public comment on issue 3, end-of-life option? Oh, I'm sorry. Senator Stone, didn't see you.
Good morning, ma'am.
Good morning, sir.
And I just, sorry I missed a lot of your presentation, but I did read the materials. I'm happy. I think I'm hearing that insurance companies aren't going to be mandated to provide this, but I just want you to know that most of the drugs that are used in the other states that allow assisted suicide are pentobarbital. And I just want my colleagues to know that it is not a very expensive drug. So it's...
Currently, the cost per prescription in Oregon is $2,000 to $3,000, which for somebody who doesn't have insurance coverage that is not inexpensive, $2,000 to $3,000.
That's not inexpensive. I agree, but I know what the active ingredients are in that we actually use them in compounding pharmacies. If they're getting that kind of money, they're really taking advantage of people.
There's only one manufacturer, right?
There's one manufacturer, maybe, but there are compounding pharmacies that can make it at considerably less cost, and I'm not advocating that any compounding pharmacies do participate in this. I'm just saying there is obviously a significant profit margin in this. I think that people with all the anxiety and fear that they have should not have to endure with a cost like this. So as you entertain these regulations, you may look at all sources of getting these medications to make sure that these families that participate voluntarily are not inappropriately burdened with the high costs that are experienced in other states.
Thank you.
Thank you very much. And with that, we'll move on to issue 4, Federal Mental Health Parity Ongoing Compliance Review, page 9 of the agenda.
Certainly. So as a reminder, federal mental health parity requires health plans to classify all benefits into federally mandated classifications, such as inpatient in-network, inpatient out-of-network emergency services, and prescription drugs. Once the benefits are classified, plans are required to ensure that the financial requirements and quantitative treatment limitations for mental health and substance use disorder are not more restrictive than the requirements or limitations applied to medical and surgical benefits in the same class. It also requires plans to ensure that any non-quantitative treatment limitations apply comparable processes, strategies, and standards to both mental health, substance use disorder, and medical surgical benefits. So for this budget change request, we're requesting $529,000 for fiscal year 2016-17 and 2017-18 for clinical consulting services to help us complete compliance reviews for new plans. This means plans that are just entering the market for the first time, or a plan that is entering a new market segment for the first time. Based on historical filings, we anticipate approximately 28 complex and 125 routine of these sorts of filings on an annual basis. There are no positions associated with this request. This is just clinical consulting dollars.
Great. Did you address the questions on the
Sure.
11 of the agenda, please.
Certainly. So question 2 had to do with the status of the front-end reviews. I will say that the compliance reviews were significantly more complex than either we or the plans anticipated. Of the 26 plans under review, 20 have completed all aspects of the front-end review. 6 plans do have some outstanding issues with respect to enrollee disclosures. These are things like updated evidences of coverage, updated notices, and the like. We anticipate that all of those front-end review outstanding issues will be completed by May of this year.
That includes Blue Cross and Cigna, because it seems that that front-end review needs to be complete before you complete your review of the merger.
Those are certainly issues that we're taking into serious consideration as we're looking at the merger. But yes, it is. The 6 plans are Aetna, Blue Cross, Blue Shield, Cigna, the County of Ventura, and United.
What's your time frame for reviewing the merger?
It's ongoing. Yeah, we just had the public meeting on March 4th, and so it's still ongoing. And if you look at the historical mergers that have been before us, I think Blue Shield is the only one that's actually concluded, and that began middle of last year. And so that one's much further down the road than the other 2 that we're looking at right now.
So will the front-end review for Blue Cross and Cigna be complete before you finalize the merger review?
I anticipate so, yes.
Okay, yes, thank you.
All right, and I believe the next question was focusing on when we were going to start the back-end reviews. So we will begin the focused back-end surveys in April of 2016. In fact, the notice to the plans announcing the beginning of the survey process was sent today, or will be sent today. The first phase of this process is to gather the necessary documentation and records and finalize all of our assessment tools, and we anticipate arriving on site in June for the first 5 plans. And then question 4 was regarding our engagement with mental health stakeholders. Historically, we've had 2 different forums for mental health stakeholders. We had one group focused on the implementation of mental health parity, and we had another that was a forum for various mental health organizations, plans, providers, stakeholders, state agencies to meet and work on issues of common interest. This year, we actually decided to combine the 2 as we're nearing the end of the front end of reviews for federal mental health parity. And the first combined meeting this year was February 26th. We have quarterly meetings, one scheduled May, August, and November of this year.
Okay, LAL Finance. Public comment, please.
Tam Ma with Health Access California. We very much appreciate, Senator Mitchell, you're raising the issue with the mergers. And we have requested that the department ensure that all plans that are seeking to merge to actually correct any outstanding deficiencies or compliance issues as a condition of the merger being review. And I also wanted to note that Aetna is actually in the process of under merger, or the department is reviewing Aetna's merger with Humana as well. And so we think that should also be addressed in the department's merger review. And we do support this BCP because we think it's very important for the department to have the resources it needs to enforce these mental health parity laws.
Thank you. Just to clarify, is that a part of your merger review that they actually do meet all of the front end, that they have a clean bill of health before you approve the merger?
Yeah, any outstanding compliance issues are either coming into compliance prior to or a plan to come into compliance depending on what the
shortly thereafter. Got it. Thank you. Next witness.
Linda Way with the Western Center on Law and Poverty. We align our comments with health access as well as the senator and some of the concerns, but do support the BCP.
Okay, thank you. We will hold this item open as well. Moving on to issue 5, large group rate review, SB 546 of 2015.
So Senate Bill 546 established additional rate review requirements in large group market, so effective on or before October 1st of this year and annually thereafter. Health plans must file additional aggregate information regarding all of their large group products. Currently, there are approximately 19 health plans operating in California's large group market. We will be posting this information on our website and also conducting an annual public meeting. We are requesting 4 permanent positions and $682,000 for fiscal year 16-17 and $644,000 for fiscal year 17-18 and ongoing to address the increased workload associated with the implementation of this bill.
And again, the regulation development timeline on page 14 of the agenda.
Is realistic. Yes.
Okay, Ms. Green, I'm making notations. Ms. Green said it's realistic. Okay. LEO, Finance, colleagues, public comment.
Madam Chair, members, Sarah Phlox from the California Labor Federation. We were one of the co-sponsors of SB 546 to bring more transparency to healthcare products in the large group market. We've been working with DMHC to put together notices, sample notices, so that health plans will be able to efficiently and adequately file all the information that is required by this law. We are very supportive of the BCP. We hope that this will be a process that will help bring more transparency and enable us to control costs in the large group market.
Thank you. And next witness.
Pam Ma with Health Access California. We strongly supported this legislation and support the BCP.
Thank you. Next witness.
Michelle Cabrera with SEI California. We also supported the legislation and support the BCP for implementation.
Thank you. We'll be holding this item open. Item 6, limitations on cost-sharing family coverage, AB 1305.
Thank you. AB 1305 makes 2 changes to existing law. For non-grandfathered family coverage, this bill prohibits a health plan from imposing a maximum out-of-pocket limit for an individual within a family that is greater than the maximum out-of-pocket limit for the self-only version. And also, it prevents individuals within a family from having a deductible that is greater than the deductible for self-only coverage in that product. So to implement the provisions of this bill, the DMHC requests limited term resources of $196,000 for fiscal year 16-17 and $188,000 for fiscal year 17-18. And this is to promulgate a regulation that will provide clarification and guidance regarding tracking the accumulation of the enrollee cost share. And it will also clarify the allowable out-of-pocket maximum and deductible limits with respect to high deductible health plans. And then, do you want me to move on to the second question? Or you?
Please do.
Okay. Second question is the stakeholder process. The formal stakeholder engagement will be encompassed within the regulation process. We're currently gathering information from stakeholders and plans to begin the stakeholder meetings in April of 2016. And we will start formal rulemaking in December of 2016. However, I will say since the passage of this bill, even prior to enactment, we engaged in numerous conversations with the plans, with other stakeholders in the author's office about technical pieces of implementation.
And it's expectation that a part of this person's time will be used to review and process legal questions. So I see that in the write-up as well. LEO, Finance, public comment.
Pam Ma with Health Access California. We were the sponsors of this legislation, which will save families thousands of dollars a year, and we eagerly anticipate the stakeholder process. Thank you.
Linda Way with Western Center on Law and Poverty. We supported the legislation and support the BCP.
Thank you. We'll hold this item open. Issue 7, outpatient prescription drug formularies, AB 339.